Hi, today we are going to start surgery, and in surgery, the first topic will be intestinal obstruction. So, in exam, the question will come like this. A 55-year-old male presents to EMD with severe abdominal pain, distension, nausea, and vomiting. He reports no bowel movement for past 24 hours. His medical history is significant for an appendectomy performed 10 years ago. On examination, his abdomen is distended and tender. Abdominal X-ray shows dilate loop of small bowel with air fluid levels. Given this presentation, what is the most likely cause of this current condition? We will solve this question later, but this is how in exam it will come. So as we know, the answer will be intestinal obstruction, but let's start with what is intestinal obstruction. So definition. When intestinal contents fail to move distally, when intestinal contents fail to move distally, that is known as intestinal obstruction. What is the etiology? Now, this is the biggest part of this topic. In exam, the causes of intestinal obstruction will come as a 5 marker. So first, very basic point. Etiology will be based on either severity, which is acute or chronic, based on blood supply, simple, strangulated or closed loop, based on cause, which is in the lumen, in the wall or outside the wall. Okay. Now, if you want to just memorize what are the causes, a simple mnemonic is at com. A. Adhesion. T. Tuberculosis. C. Crohn's. O. Obstructed hernia. M. Malignancy. Simple at com. Now this is the diagram. Let's see. Adhesion. As you can see, these are the adhesions. These are the adhesions. Adhesion are like 40% of the cases will be due to adhesion. Okay. Now tuberculosis. Tuberculosis will cause ileum stricture. Ileum stricture. Crohn's, 15% of the cases, obstructed hernia. Obstructed hernia. Then malignancy. Now here I have shown four malignancy. One is rectal carcinoma, then carcinoma cecum, then carcinoma hepatic flexure, and then carcinoma splenic flexure. So five main causes at com: adhesion, tuberculosis, Crohn's, obstructed hernia, malignancy. Then what are the other causes? Then you can say sigmoid volvulus or Meckel diverticulum or intussusception or fecolith. These are fecolith. Okay. These are the causes. ADCOM, adhesion, tuberculosis, Crohn's, obstructed hernia, malignancy. Now pathogenesis. Now let's see pathogenesis. So first there will be intestinal obstruction, as you can see. Because of this intestinal obstruction, there will be distension due to gas and liquid and feces collection. This distension will cause venous compromise. Because of venous compromise, there will be congestion and edema. Because of this, there will be arterial compromise, thus gangrene. Where there is gangrene, there is bacterial proliferation. Bacteria will release toxin, which will go to circulation and peritoneal cavity, which will lead to septic shock. So this is the diagram which you can follow. Intestinal obstruction, then distension, then venous compromise, arterial compromise, gangrene leading to bacterial proliferation, toxins in circulation, then septic shock. So we are done with definition, etiology, pathogenesis. Now let's talk about clinical feature. Clinical feature symptoms will always be same. Four symptoms: abdominal pain, vomiting, constipation, abdominal distension. So if abdominal pain is central, then it is small intestine. If it is peripheral pain, then it is large intestine which is involved. If vomiting is bilious, which means it is yellowish color, then it is jejunum or simply small intestine. If it is feculent, then colon is involved. If vomiting comes early, then it is small intestine involved. If it comes late, then it is large intestine wall. And completely opposite in constipation. If in constipation comes early, then it is colon. If constipation comes late, then jejunum or small intestine. In abdominal distension, if it is mild abdominal distension, then jejunum. If it is severe, then colon. So by this we can tell where is the intestinal obstruction. Now let's talk about signs. So there will be signs of dehydration such as dry tongue, dry skin, sunken eyes, and oliguria or low urine output. Then abdominal examination. Always remember IPPA. Inspection, palpation, percussion, auscultation. Inspection, abdominal distension. Palpation, we will do hernia examination, whether it is obstructed hernia or not. On percussion, there will be tympanic note. On auscultation, this word is there. Borborygmi sound. Borborygmi sound, which is loud and noisy intestinal sound. Okay, signs are done. Now we'll talk about investigation. What are the investigation? First, we will do CBC. In CBC, there will be increasing WBC, which will show there is infection. Plain X-ray will show plain X-ray abdomen erect will show multiple gas fluid level. This is the X-ray. As you can see, 1, 2, 3, 4, 5, multiple gas fluid level. Then one can do barium meal follow through, but we don't do this in total obstruction. And when we are doing this, we will use a very thin consistency barium meal follow through. What is it? It's a contrast enhanced X-ray. Simple. USG abdomen and CT abdomen. Now, what is the treatment? You can remember treatment by this A, B, C, D, E, F. A for aspiration with rise tube to decrease distension. B for bowel care, which means we don't give any purgative. Then C for charts. Charts monitoring such as temperature, pulse rate, respiratory rate, and input output monitoring. D for drugs, antibiotics to kill bacteria and not let septic shock to happen. Then exploratory laparotomy and fluids and electrolytes. Now in exploratory laparotomy, we will do a midline incision, large incision, and then if there are adhesion, then we will release them. If there is stricture due to TB, then we will dissect them. If there is obstructed hernia, then we will try to reduce or resect it. Resect in the case of gangrene. And if there is malignancy, then we will try to bypass that malignancy. This is the treatment. So we are done with the topic. Now we will again go to the question. So there is severe abdominal pain, distension, nausea, and vomiting. So definitely intestinal obstruction. No bowel movement for past 24 hours. That is the definition. No bowel movement. Then medical history shows there is an appendectomy. So appendectomy means a surgery. Surgery will causes adhesion. As we know, adhesion are the 40% cause of intestinal obstruction. So here the diagnosis is intestinal obstruction due to adhesion. Thank you for watching the video. I hope you liked it and please subscribe. We'll continue the surgery videos as well as medicine videos. Thank you.